All right, everyone. Thank you so much for joining us for our monthly webinar. This is DMC Medical Group Heart to Heart webinar. We're going to come to you as usual on the last Thursday of the month from 12 to 1 with experts from cardiology and other specialties as well, talking about a different topic in the community to our community as well. I would like to introduce our chair of cardiovascular service line, Dr. Kenton Zair. He's a professor of medicine at Wayne State University. He is our cardiothoracic surgeon. He's leading our program in Michigan for cardiology. And me, I am interventional cardiologist at Detroit Medical Center, and will be your host today. But Dr. Zair will be moderating the session. Few housekeeping items. Please make sure you use the Q&A box for any question that comes up while our speaker is conducting the presentation. With that, we'd like to start with introduction video about Detroit Medical Center in Michigan. So our community is built on care, and Dr. Abir Berry joining us from Huron Valley site. Dr. Abir Berry grew up in Southeast Michigan. She completed all her training in Michigan, including residency, cardiology, and now she is part of our team as well. Her clinical interest is preventive cardiology, women's health, and cardiac imaging. Dr. Berry, I met her multiple times at local and national meetings. She presented multiple research articles as well as was part of multiple committees on the ACC Michigan chapter and other societies as well. Dr. Berry, thank you so much for putting these slides together. You're going to talk to us today about heart health and women. Please go ahead with you and Dr. Zair.
Okay, Dr. El Reyes, thank you so much. Dr. Zair, thank you so much. So today I'm going to be talking about women and heart disease. There's a lot to cover. Just going to brush upon most of the many of the issues that we deal with in women's healthcare when it comes to cardiology. I'm going to go ahead and share my screen right now. Hold on. All right, again, so just to make this as simple as possible, talking about women and heart disease. So in the United States, as you can see, heart disease does affect many women. Is there a way to hide this? Yeah. Okay. So just looking over here, especially in the area that we live in the Midwest, you can see by age groups and women that are over 35, the age adjusted average per annual rates. And clearly you see it's pretty dense here in the southern aspect of the country as well. So there aren't many women that are aware, but only about 56% of women recognize that heart disease is their number one killer. It is the leading cause of death in women in the United States. It's responsible for 20% of female deaths. It's the leading cause of death in white and African American women. As for other races, heart disease and cancer are tied, or cancer comes as a close second, or heart disease comes as a close second. 1 in 16 women aged 20 or older have coronary artery disease, specifically 1 in 16 white, Black, or Hispanic women, and 1 in 30 Asian women in America. So first, I'm going to start talking about the general risk factors for cardiovascular disease that are risk factors for both men and women, and I'm going to brush upon the differences between the genders when it comes to the general risk factors, and then I'm going to go into the risk factors for women themselves. So as we all know, age is one of the major risk factors for developing cardiovascular disease. Here's a study from Jack back in 2013. Between greater than 3.6 million people were studied that were age 40 and older. They underwent ABIs, carotid duplexes, or abdominal ultrasounds, and they found that as we age, we all tend to have more vascular disease. It's definitely more prevalent. So family history of premature coronary artery disease also puts both men and women at risk for coronary artery disease themselves. So if you have a first degree relative that's a male that's greater than the age of 55, or females greater than the age of, before the age of 55, or females less than the age of 65 that have coronary artery disease and they're a first degree relative of yours, you're at higher risk for developing premature CAD. High blood pressure. So there was a study that showed this. Women, the prevalence of hypertension in women greater than 60 years of age was 70 to 80%. And in comparison to men, hypertension is a stronger predictor for coronary artery disease. So it plays a bigger, it's more likely to be a stronger risk factor in women than men in developing heart disease. The management, however, remains the same between men and women. Hyperlipidemia. So lower HDL is a higher risk predictor for females than higher LDL for developing heart disease. Lipoprotein A may determine heart disease in premenopausal women and postmenopausal women that are under 66 years of age. Only time elevated total cholesterol is affiliated with higher risk of CAD is if women are premenopausal, or if the levels are extremely high, meaning more than 265 milligrams per deciliter. Triglycerides influence coronary risk, specifically in elderly women and when they're more elevated than 400 milligrams per deciliter. And this study here was in JAMA in 2005, showing that LDL plays a role in developing coronary artery disease in women. But as you can see, the non-HDL, high sensitivity CRP, HDL, the total cholesterol to HDL ratio is more indicative of developing of a hazard ratio for developing heart disease in women. So what about statins in women? The role of statins in women is somewhat uncertain because all the studies that were done on statins had an under-enrollment when it came to women. But here's a study here from Lancet in 2015 showing the efficacy and safety of LDL lowering therapy in men and women. And they did find that statins do work in women, especially when used at higher doses than lower doses. But
Abir, I have a question for you. You raised a very good point here. You mentioned that there is low enrollment of women in trial. Now you mentioned statin, but this is the pattern across any trial.
right.
We would be really lucky to have more than 27% women included. What do you think the problem here?
I think it's the recruitment, and I think, again, it goes back to the same point that I brought up early on in the discussion, in the presentation, was that women tend to undermine their risk of coronary artery disease. So, and I think that's amongst the general population, that we're not understanding that, 20% of women do develop coronary artery disease, especially in the United States. And so I think it plays a role in recruitment and just, not knowing that coronary artery disease is still plays a major role in the lives of women.
Now, I'm a surgeon, so I kind of maybe missed it, or I don't know as much as I should about lipid profiles. But is it true that lipid profiles are different in women than they are in men?
So again, I'm not sure exactly of whether the breakdown is different in women than in men, but I do know that the HDL and the triglycerides play a bigger role in women than they do in men.
Got it. So is that a reason why women are less apt to be put on a statin?
Yes, it may be. As we know, statin therapy tends to lower LDL more so than lowering triglycerides, and doesn't play a big role in HDL. So definitely that may be a reason. Another reason is, from my clinical experience, a lot of women complain about muscle aches more often than men do. They're more scared to take higher doses despite them having the same risk factors.
And actually, you're right, Abir. Also, they are less likely to be tested, because you see a man, a man smoker, say, "Oh, you have to check your lipids," but a woman have indigestion. Really, the chances of testing her lipids is not too high, because we think they don't get the disease, that's why we're doing this.
Right. And even clinically, when we're speaking, right, when we're calculating the risk scores for these patients using the ACC-AHA risk calculator, even with higher LDLs, older women, their risks are lower. So even if their LDLs are not matching, the levels that you would put someone on a statin, their risks are lower, and just putting them on a statin just for their risk tends to be lower. So you're less likely to put them on the statin for that reason as well. Carry on.
Oh, please. Yeah, go ahead.
All right. Okay, so this is just like one example right here. This is a study done back in 2004 in JAMA as well, effective intensive compared with moderate lipid-lowering therapy in patients for progression of coronary atherosclerosis. And as you can see here, look at the enrollment of men. 73% of the men, of the patients that were studied were men. And then with the intensive therapy here, 71%. So this is just one of many studies. If you go through multiple studies about lipid-lowering therapy that show that men are more likely to be studied. So other general risk factors, as we know, diabetes is considered a coronary artery disease equivalent in both men and women. But interestingly enough, the risk is greater in women than in men. So the study here in BMJ, as you can see, the relative risk of developing heart disease in women compared to men, even when it was age adjusted, was higher in diabetic women than in men. So glucose intolerance itself, even if it's below the definition of diabetes, and can increase your risk of cardiovascular disease, and your risk of cardiovascular disease will increase with increasing levels of A1C, even if the A1C is under 6.5. CKD itself is an independent risk factor of CAD in both men and women. And if you have pre-existing CAD and you develop chronic kidney disease, it worsens your pre-existing coronary artery disease. And this is seen even with mild to moderate renal dysfunction. Metabolic syndrome, as we all know, consists of abdominal obesity, hypertension, hyperlipidemia, prediabetes, or diabetes. That in of itself in both men and women will increase your risk of developing coronary artery disease. Cigarette smoking. So half of the coronary events in women have been associated with cigarette smoking. The risk of developing coronary artery disease in women that smoke cigarettes is even elevated in those who smoke even as low as 1 to 2 cigarettes a day. And in comparison to men, their risk of developing coronary artery disease from smoking is increased by 2-folds with smoking compared to 3-folds with women. So clearly this study here shows that. This is a study again from the BMJ in 2018. If they were a former smoker versus never smoker, their risk, and then current smoker versus never smoker, and we see that the hazard ratio is higher in women than it is in men.
Why is that?
I'm not 100% sure why that is. That's just, I do know that, women that tend to smoke are more likely to develop microvascular disease. And I also, I don't know. And the other thing about women that I'm going to bring up shortly is that they tend to have a more likely risk of developing coronary artery disease if they have elevated CRP levels. So I don't know if that smoking increases inflammation in their bodies, and that's why they develop more coronary artery disease from smoking. Carry on?
Yes.
Okay. All right. So if smoking cessation just in women compared to men, same thing, there's a rapid reduction in the risk of smoking. Most of the risk goes away within 2 to 3 years of smoking. So here in this study, this is an old study back in 1990 in the New England Journal of Medicine, current smokers, a relative risk of developing an MI. And then 3 years within smoking cessation, they start to level off with their risk of having a heart attack being similar to someone who's never smoked. So after about 3 years, like I said, it's indistinguishable from those who've never smoked. Diet, as we all know, increased intake of fruits, vegetables, beans, fish, poultry, whole grains, and reduction of red and processed meats and sweets and refined grains lowers the risk of CAD in comparison with those that make opposite diet choices. This is both true in men and women. Obesity, In both men and women, a BMI of greater than 30 is associated with coronary artery disease. The Nurses' Health Study that studied 115,000 middle-aged women over 8 years found that a BMI of greater than 32 was associated with death from either coronary artery disease or cancer. Interestingly enough, even if you gain weight and you remain in the normal BMI range, it was noted to see that there was an increased risk of developing CAD, and abdominal obesity, as we know, is more predictive of overall body mass. And gaining weight after the age of 18, even if your BMI was normal, was also found to be a risk factor for CAD. Alcohol intake, more than 2 drinks a day, was associated with high blood pressure. Mild to moderate alcohol intake may have a cardioprotective effect in men. It's seen in women as well, but the problem is there's an increased risk of breast cancer with doing so. There's a prospective study of 85,000 middle-aged women with no history of CAD. The relative risk of death in drinkers versus non-drinkers was 0.8 in those who drank 1 to 3 drinks a week. 3 to 18 drinks per week, the risk went up to 0.88, and 1.19 with more than 18 drinks a week. Light to moderate drinking was associated with a decreased risk of coronary artery disease, but then it's heavily weighted against the risk of death from breast cancer or with heavy drinking cirrhosis.
Basically, what you're telling at Abir is anything that we always thought that affect men for getting coronary artery disease is exactly the same as women. But I think you're going to come and tell us later on that post-menopausal women with this risk factor, the burden of the disease is even bigger.
Yeah, I'm about to finish up with the common risk factors between genders, and then I'm going to move into the risk factors that are specific to women.
Sounds perfect.
Yeah, it's really it's eye-opener for us. I mean, we have to be more aggressive when we evaluate women when they come to clinic with indigestion or anything. As cardiologists, and also for primary care who are listening to us, they should be at least proactive in evaluating this risk factor.
Well, already I learned that smoking is a higher risk factor for women than men. I was completely unaware of that before that slide 3 slides ago.
Right. So that's why I wanted to talk about the general risk factors, because just because we're aware that, hypertension, hyperlipidemia, diabetes, whatnot, can play a role in developing coronary artery disease despite the gender, it's important to be aware of the differences in the hyperlipidemia, understand that diabetes is a bigger risk factor for women, understand that hypertension is a bigger risk factor for women, and so is smoking. So again, sedentary lifestyle, obviously you want to tell your patients to exercise. Even at moderate levels, it can protect against coronary artery disease and all-cause mortality. So psychosocial risk factors, this plays a role in both men and women, but it affects women more. So lower socioeconomic status in both genders affects the risk of coronary artery disease, but more so in women. So they tend to have more coronary artery disease, and they also tend to have worse outcomes. So interestingly enough, this was a study that I found where they'd studied women with marital stress, work stress, or living alone, and they found a 3-fold increase in risk of cardiovascular disease in women just from marital stress alone. And you can see here the p-values compared to work stress values. Depression. This study was done in women that were postmenopausal with depression, and this was their, survival. And you can see clearly that the depressed population was less likely to survive in both, in 3 groups: stroke, cardiovascular death, and all-cause mortality. So I brought this up earlier, but the inflammatory markers in women, CRP was a strong independent risk factor for cardiovascular disease, and its value was greater than LDL cholesterol. So maybe that plays a role in why smoking increases chance of coronary artery disease more than it does in men. And clearly you can see here, this study was in 2000 New England Journal of Medicine, where they studied different molecules to see if they increase the risk of coronary artery disease, and they found that high sensitivity CRP in women really increased their risk of CAD, even more so than LDL. So moving on to risk factors that are unique in women. There are multiple risk factors that are unique in women, but the problem is there are no specific interventions to modify the effect of these risk factors. The only thing that we really can modify is avoiding estrogen, progestin, contraceptives in women that have many risk factors for developing coronary artery disease. So here's a meta-analysis that was done on the time that women went through menarche. And they found that death from all causes was increased in women who had early menarche, meaning before the age of 12, as compared to those at 12 or older. So your risk factors as a woman for developing coronary artery disease start at a very young age. So going on to menopause, as Dr. El Reyes was talking about, the ACC-AHA does recognize it as a risk factor for coronary artery disease, and they weight it the same as male gender. But it's hard to tell how much menopause itself plays a role in developing coronary artery disease, because menopause occurs also at an older age. And as we know, as we age, we're more likely to develop CVD in general. Early menopause has been shown to be associated with higher risk of coronary artery disease, and the higher risk for CAD is unclear, and hormone replacement therapy has not been shown to be protective. So here is a study where they went ahead and looked at hormone replacement therapy, and they saw the benefit or risk of doing so for multiple reasons. And you can see here clearly that patients that received hormone replacement therapy had more coronary artery disease and had more pulmonary embolisms and more strokes. So it was helpful for hip fractures and I guess colorectal cancer, but definitely not helpful for coronary artery disease or other arterial or venous thrombotic events. What about hysterectomy? There was an observational study where they studied 90,000 postmenopausal women. 40% of them had undergone hysterectomy with or without oophorectomy, and they found that this was not associated with a significant increase in total mortality or of fatal or non-fatal cardiovascular disease. And this is where the question comes: is it menopause itself that makes women develop that increases their risk of coronary artery disease? Or is it just their increasing age? Because these women had a hysterectomy and did not have increased CAD. What about premenstrual syndrome? As we know, it's associated with physical or emotional symptoms occurring a few days prior to menses. PMS has been shown to be associated with future development of hypertension, and specifically early onset hypertension, so prior to the age of 40. And as we know, hypertension can increase your risk of CAD. So in some way, it is associated with a higher risk of CAD. What about oral contraceptives? They might increase your blood pressure a little bit, but blood pressure will remain within normal range. Overt hypertension has not been seen with current contraceptives. There's a 3 to 5-fold increase in venous thromboembolic events with all types of oral contraceptives. In general, the risk of VTE is low in females, but the risk that you develop from OCPs is usually highest in the first few months of use, but it's still lower than the risk that a woman may have during pregnancy or early postpartum period. And so it's important to recognize patients that have higher risk factors of developing VTE, like patients with thrombophilia, smoking, obesity, PCOS, older age, or immobility, and recognize those patients may not be the best candidates for oral contraceptives. And progestin data alone has not been consistent with risk of thrombosis. This is more with combined or estrogen alone. MI and strokes are very rare from contraceptives, but they are still 1.6 times higher. There's a higher risk of developing them than with non-users of OCPs. And OCPs may raise triglycerides and reduce insulin sensitivity, but the current formulas, their effect is negligible in this sense. What about PCOS? As we know, it can be associated with metabolic syndrome, so it may increase your risk of CVD, but the risk of CVD from PCOS alone has not been established. What about patients with breast cancer? With radiation therapy, if they receive radiation therapy from breast cancer, there's an increased risk of coronary artery disease that starts a few years from the time of radiation therapy. So usually 5 years after radiation until 20 years after radiation. And it is proportional to the dose that they receive. It's more likely to occur in patients that already have underlying CAD, but more commonly from radiation therapy for breast cancer, we see heart failure, restricted cardiomyopathy, valvular heart disease, constrictive pericarditis, and pericardial effusions. Chemotherapies for breast cancer, as we know, anthracyclines could be cardiotoxic. Again, it's dose dependent. That's the strongest risk factor for you to develop cardiotoxicity, depending on how much you receive. Also, what plays a role is the age that a patient receives anthracyclines, whether they're receiving other chemotherapy along with it, whether they're receiving radiation with it, and whether they have pre-existing heart disease, high blood pressure, diabetes, or peripheral vascular disease. Anthracyclines can cause cardiotoxicity from the time of treatment to months after treatment cessation, and sometimes years later. If it does develop years later, it may be a systolic or diastolic dysfunction, and it may be fatal. And you can see a reduction in LV function up to 30 years after treatment. Trastuzumab as well causes an asymptomatic decrease in LV function, but less likely that patients will develop clinical heart failure. Again, more likely to develop if you're using it along with anthracyclines, and it's more likely to develop if the patient already has an underlying lower EF, they're older, they're obese, or they're on antihypertensive. And it's also not dose dependent. So unlike anthracyclines, it's not dose dependent. What about tamoxifen and aromatase inhibitors? So aromatase inhibitors work better than tamoxifen, but the problem is they have a higher risk of cardiovascular disease than the SERMs. They tend to have a similar risk for patients to develop MIs or strokes, but they're more likely to cause valvular heart disease, pericarditis, and arrhythmias. Preeclampsia. Preeclampsia is when patients after 20 weeks of gestation, pregnant patients 20 weeks after gestation develop blood pressure issues with blood pressure greater than 140/90 and are found to have significant protein in their urine. This is a recent study that came out just a few months ago where they found that women that have had an episode of preeclampsia in the past were more likely to develop coronary artery calcification. So compared to women that never had preeclampsia, they found that women were more likely to have coronary artery calcification, and they were more likely to develop it earlier. So 5 years earlier than women that have never had prior preeclampsia. And a third of a woman with a history of preeclampsia were found to have visible plaque formation on CTA, and 3% had significant stenosis. So these complications in pregnancy are not to be taken lightly. There was another large cohort study that found a 3.6-fold increase in cardiovascular death at the age of 60 for women who have had early onset preeclampsia developed by 34 weeks of pregnancy compared to women who never had preeclampsia.
That's very significant data. And when I was reading that paper, Abir, and thanks for bringing it up to the audience, it's an eye opener because we see a lot of patients who are been pregnant before, but I never ask in my history, have you been through preeclampsia before?
I ask that every time: preeclampsia, gestational diabetes, and pregnancy-induced hypertension.
I have to admit, I don't know, Dr. Zair, if you do the same. You're muted, Dr. Zair. Yeah, if you do the same, but I have the same issues. I mean, I never till I read that paper. Go ahead, Dr. Zair.
It makes total sense because preeclampsia it releases cytotoxins.
Yeah,
it's an endothelial injury, and it's probably fairly significant. So one could postulate that that's the setup for coronary artery calcification. Very interesting data.
So,
yeah,
preeclampsia, it increases your chance of developing cardiovascular disease by 2-fold later on in life. So it is a major thing, and it should be asked in all our female patients.
Exactly.
And then going on, this goes almost hand in hand. So then we have our population of female patients that don't develop preeclampsia, but they develop gestational hypertension. So this actually came out recently as well. This just came out, this month. It's coming out in JACC this month. But they looked at the echoes of patients that had a normotensive pregnancy and are currently normotensive versus patients that had hypertension just in their pregnancy or they currently have hypertension versus patients that had hypertension in their pregnancy and currently have hypertension. And we see the increase in LV wall thickness is highest in those that had both high blood pressure in their pregnancy and high blood pressure currently, as compared to patients that are currently hypertensive or just had high blood pressure in their pregnancy. And we see more remodeling. And we also see a change in the mitral valve inflow, meaning they're more likely to develop diastology.
Appreciate.
Gestational diabetes. Most women that develop this are normoglycemic post-delivery, but they're high risk for recurrence of gestational diabetes if they get pregnant again, prediabetes, overt diabetes. There's a tenfold higher risk of overt diabetes if they've had gestational diabetes. Metabolic syndrome, even type 1 diabetes, they're more likely to develop, and cardiovascular disease. Spontaneous pregnancy loss has been shown to be a higher risk for MI later in life. Spontaneous delivery before 37 weeks, so preterm delivery, was associated with increased risk of cardiovascular disease than those who deliver at term. Placental abruption was also associated with higher risk of cardiovascular disease. Peripartum cardiomyopathy, I'm going to talk about that further right now. So peripartum cardiomyopathy is very interesting. I actually have a lot of patients that have recovered peripartum cardiomyopathy. So they have an LVEF of less than 45% that's found at the end of pregnancy or during delivery, and where you can find no other cause of this heart failure. The incidence in the United States is between 1 in 1,000 to 1 in 4,000. You're more likely to develop it if you have African ancestry, preeclampsia, hypertension, multifetal pregnancies, and older maternal age. The etiology is not really understood. We think it's related to hormonal changes and prolactin breakdown, which has vasculotoxic effects. You need to diagnose it with an echo. You need to rule out a thrombus. And adverse outcomes are more likely to happen if the EF is less than 30%, if you have concomitant obesity, preeclampsia, dilatation of the LV, RV systolic dysfunction, and thrombus. It's more likely to be have higher rates of recovery compared to other forms of heart failure, and recovery may take up to 2 years. How do we treat it when these patients are pregnant? Loop diuretics, beta blockers, DIG, hydralazine nitrates. As we all know, we can't use any of the renal angiotensin aldosterone inhibitors during pregnancy. During lactation, however, you can use enalapril, captopril, and spironolactone. If the EF is less than 30%, they do recommend anticoagulation by the AHA. And up to 8 weeks postpartum, which gets kind of complicated, as we know, because warfarin is contraindicated in most parts of pregnancy, but you can use low molecular weight heparin, and we haven't studied any DOACs in pregnancy. We don't know the role for bromocriptine, and it's the most common cause of cardiogenic shock during or shortly after pregnancy. You can't give nitroprusside due to cyanide toxicity, and the outcomes with dobutamine are actually worse. And cardiac transplant in these patients have been associated with higher rejection rates and lower survival. If the patient's hemodynamically unstable, you should consider early delivery. You can deliver vaginally in stable patients, and because there's some implication of prolactin with peripartum cardiomyopathies, the 2010 European guidelines advise against breastfeeding. There is a small observational study in the US that was done that showed that breastfeeding is safe, but there's not enough data on that. We also don't know about the arrhythmias with peripartum cardiomyopathy. You should consider contraception as soon as possible and avoid estrogen. Continue their medications if the cardiomyopathy persists, and counsel for further pregnancies, and let them know that there's worse maternal or fetal outcomes if the LV dysfunction persists. And even if their EF recovers, they're still at risk for redevelopment. If the patient does have LV dysfunction, you follow them with the echo, BNP, and clinical exam, and you stop the ACE and ARB if they decide to get pregnant again. So what about symptoms in men and women when it comes to coronary artery disease? So as you can see here, women and men tend to both have chest pain, shortness of breath, nausea, and vomiting, jaw, neck, back pain. But women can have fainting, and as Dr. El Reyes has mentioned, indigestion. They may be extremely fatigued. They tend to complain of upper back pain and abdominal pain. So this came out last year. sex differences and symptom presentation in ACS. They looked into 27 studies, and they found that women with ACS had higher odds of presenting with pain between their shoulder blades or nausea and vomiting and shortness of breath. They had lower odds of presenting with chest pain or sweating, diaphoresis. Most sexes presented most often with chest pain, though. Other symptoms also showed substantial overlap in prevalence. So despite us always thinking that women are going to present with indigestion, nausea and vomiting, pain between their shoulder blades, most often they still presented with chest pain. So some of the symptoms do actually overlap between men and women. So women that have ACS, they're more likely to develop heart failure than men do post-MI. And it's thought to be due to that they are more likely to develop diastolic dysfunction than men do. We're not sure why, but it might be because women tend to have more hypertension than men do and more LVH than men do. 38-year follow-up of the Framingham Heart Study looking into the rate of sudden cardiac death in women in comparison to men found that there was lower episodes of sudden cardiac death than men. Actually, half of that compared to men. What about when diagnosing female patients? And this is not ACS patients, we're talking about stable angina patients. So there's higher false positive rate of obstructive cardiovascular disease, CAD in women, and it's thought to be due to lower prevalence in women in the population studied, older age for women, so they're more likely to have a false positive stress test. Lower exercise capacity, we expect that women usually have 2 METs less than men do on an exercise stress test. Hormonal medications and autonomic fluctuations may also play a role in why women tend to have higher false positive rates of on stress tests. Stress echo and nuclear imaging usually have similar sensitivity and specificity in men and women. We have to be aware of the breast artifacts and nuclear imaging that's more common in women, as we know. And we have to be concerned when we're exposing young women to radionuclide imaging and coronary CTA because the radiation exposure and their risk of breast cancer, but nothing has been shown convincingly to be harmful yet.
What would be your preferred way of evaluating heart disease in women in terms of stress test?
Like stable angina?
Yeah.
We run through problems with insurances and whatnot, but I do like a combined study in women for those reasons of false positive rates of stress EKGs. Even if they're lower risk, it'd be nice to be able to combine an imaging modality.
Echo or no? Do you have a preference for echo or nuclear?
I think with more, if they have more comorbidities, and especially if they're diabetics, I tend to go more with nuclear than stress.
More sensitivity. Yeah.
Yeah.
Dr. Berry, does that mean if you have a fairly positive test using one modality, you still get a second modality? Or does it mean that if you have a negative one, you always get a second modality? Understand the question?
Yeah, I do. I think you have to take everything into like clinical context, right? So the patient has a very positive stress EKG and she has no symptoms and she goes 13 METs on the treadmill. That's more likely to be a false positive stress test that I feel in that case, if I wanted to confirm something, maybe getting another modality or just leaving it alone and saying that this is probably not really ischemic heart disease, as opposed to someone who has to stop because of chest pain or, difficulty in breathing, has below average metabolic capacity. And, in that case, if everything fits, you may not even have to do another imaging modality. You may just go straight to, a cath if needed. Okay. All right, so as for ACS, the evaluation for ACS in men and women is similar, but studies have shown that high sensitivity troponin at baseline is lower in females than males. There are multiple studies showing gender disparities in the care of females compared to males when it comes to ACS. Females are half as likely to be taken for coronary angiogram than men do when it comes to ACS, and they're also 50% more likely to pass from ACS than men will. So higher mortality and less likely to be taken seriously. When it comes to coronary angiogram in general, diagnosis of normal coronaries is 5 times more likely in women than men with stable angina, not with ACS. And why is that? There's definitely other causes of chest pain that's not related to obstructive CAD. Cardiac syndrome X, microvascular dysfunction, is present in 20 to 50% of women with chest pain and normal coronaries. Stress-induced cardiomyopathy, Takotsubo, precipitated by psychological stress, primarily in postmenopausal women. SCAD accounts for a quarter of ACS in young women. Coronary vasospasm, which sometimes goes hand in hand with cardiac syndrome X and Takotsubo, is more likely in women. So women that come in for an NSTEMI or unstable angina, they're more likely to have worse outcomes due to older age presentation, and they're more likely to have comorbidities like diabetes and hypertension. So their outcomes are thought to be worse even when taken for coronary angiogram, because they tend to present at an older age, and they tend to, because of their older age, they tend to have more comorbidities than the men that come in with NSTEMIs. Women with STEMIs have higher risk of cardiogenic shock, and they also have higher risk of in-hospital mortality with the cardiogenic shock. Again, like I've mentioned before, hormone replacement therapy is not recommended for cardiac protection in women with CAD. Patients that come in with NSTEMI or unstable angina, the early invasive strategy was more beneficial in higher risk women, where the risk did not affect benefit in men. Early revascularization, of course, is equally beneficial in both genders when it comes to a STEMI. And after TPA or primary PCI, women are more likely to have a higher risk of bleeding, but the benefits from therapy still outweigh the risk. And this is mentioned before, statin therapy is underused in women for secondary prevention despite similar benefits to men. And that's all I have for you today.
That's great. Thank you so much, Dr. Berry. There's any comments from you, Dr. Zair? I want to ask you a question for Dr. Zair before I entertain a couple of questions from the audience. Do you have any difference or approach for women undergoing cardiac surgery, left main or trivial disease? Would your approach be different in terms of technique or even pre or post care?
Well, there are several caveats to that question. One is, should we utilize double internal thoracic arteries in patients, in women, equally to men? And in the era of skeletonized harvesting of both internal thoracic arteries, there is no evidence whatsoever that women have a higher risk of mediastinitis after taking a second mammary compared to men. I'm unaware of a single study. And one could imagine why that query gets raised, because women have breast tissue outside of in the same distribution that the internal thoracic artery feeds, and maybe you would contemplate that you're devascularizing the chest wall more than in men, but that is not true at all. So if you're a young woman and you're coming to coronary artery bypass grafting, you should ask your surgeon if they're going to do double internal thoracic arteries on you. I think that's totally appropriate. There have been multiple studies over the years showing worse outcomes in women than men. And I think that if you, and they're on both sides of the fence, is it something intrinsic to women that makes their outcome with bypass grafting less durable than with men? And I think the prevailing conventional wisdom is that it's primarily related to coronary size. Women generally have smaller coronaries than men, so it follows that maybe their grafts will not stay open as long as men. In that sense, I tend to err on the side of doing double mammaries in women, because if you sew a good internal thoracic artery on some graft, it's going to stay open forever if you sew it well, and if they don't get disease beyond where you put your anastomosis. So I think one of the things that we're seeing in the surgical literature, and also the surgical mentality, is to push the double internal thoracic artery in women equally as to men. So I think about it every time somebody comes to me that's less than 70 years of age. I think no matter what, whether they're a man or whether a woman, I would tend to put double mammaries on them. And I think that in some ways, maybe we should think about it more vigorously in women than men because their coronaries are smaller and we know those arteries are going to stay open. But other than that, there's really no difference. The way we treat them, the heart looks the same on a man and on a woman. When you open up the chest, you can't tell any anatomical difference, you know?
Absolutely. In terms of post-care, post-cabbage, I don't know, this is my observation. The women tend to have some more pain. Is it because their tendency, their pain tolerance is lower than men? Or just happened coincidentally, the woman I had post-cabbage care tend to be more in pain than others?
I'm going to disagree with you on that one. Because like I tell all my patients before surgery, if you're young and you're a man, you're going to be crying. If you're older and you're going to be on opioids, and if you're older and you're a woman, we're going to have you on Tylenol and you're going to say it's not that bad. And then I tell all my patients, everyone else is somewhere in between.
Yeah.
So my experience is that elderly women experience very little pain from the median sternotomy, and younger men experience a lot more. Now, my male argument to that is that men's ligaments are a little tighter. They have, when you stretch them open, they have pain in their back. I tell them it's like breaking the binding of a book. And that's why they have base of the neck pain and back pain, because the body was not meant to be, the ligaments in the back were not meant to be stretched like this. Now, and also the pectoralis muscle tends to decussate in the midline. So we all know muscle hurts more than anything else, muscle and bone. And so when you cut down through that decussated muscle in a man, those pectoralis muscles hurt a fair bit more. So I think women have less pain from that skin and subcutaneous and muscle incision than men do. So my experience has kind of been the opposite, that women experience the pain better, at least in the post-op period, you know, between 0 and 10 days post-operatively. Now, you know, the aches and pains that happen, you know, 6 weeks down the road, that's you know, and Abir can weigh in on this as well, because she sees those patients, you know, at that stage. But that's why I would disagree. My experience is that women tolerate the pain better than men post-operatively.
They definitely do.
What do you have to say, Abir?
I definitely agree. I don't think you, I don't know what kind of pain receptors you were born with, but it's not similar between us.
So Abir, a question: if you get a patient who told you I have significant family history, a female patient of heart disease, and she's postmenopausal, what is the workup that you do for primary prevention for this woman?
I definitely, you want to start with, you know, making sure the vital signs are okay, no high blood pressure, whatnot. You want to ask those questions. You know, what time, when they started having periods, when they reached, if they reach menopause, when they reach menopause. Yeah, you want to make sure that they don't have elevated blood pressures. You want to run labs, make sure what their cholesterol panel looks like and whatnot. Calculate an ASCVD risk score in them, and you know, I always offer a calcium score in someone who's got especially a premature family history, and whatnot.
Dr. Berry, historically, we've always said that women are protected due to a hormonal advantage for maybe 5 to 10 years longer than men. But most of your data suggested that we should take symptoms and everything just as seriously in women as men. Now, is it still true that women present 5 to 10 years later with coronary artery disease than men as a general rule?
The question, Dr. Zera, if women present prematurely like men again?
No, I'm saying in the past, we've always said that women, their coronary artery disease tends to present 5 to 10 years later than men, given the same age. And I think we might have lost Abir. But the question is that still true?
I see. She lost her. Yeah, but I think based on what she showed us, it looks like you treat the woman as serious as men.
Exactly. But she did have one slide that said 65 versus 55. That's why I asked the question.
Right. There's a question coming from Rabia. Should we get apoprotein B level and when triglycerides are elevated? Is this seen as a significant factor on women? Um, okay, and the other one, which patient would be ordered a lipoprotein AN? Well, again, this is if you have a family history of familial hypercholesterolemia, definitely you have to do extensive workup, especially in patient who has premature coronary artery disease. So lipoprotein A, lipoprotein B is I almost get them routinely in patient with high risk profile, even in the setting of normal LDL. Amir
Here.
is back. Yeah. Okay. Great.
You're back.
Yeah, so I did mention, yeah, you definitely want to take symptoms into consideration, but there was one slide where I did mention that it's highly unlikely that women are going to have significant coronary artery disease if they're premenopausal, if they have no other traditional risk factors.
Yeah.
If someone's premenopausal with traditional risk factors, comes in with chest pain, should be taken as seriously as any man with traditional risk factors should. But if they're premenopausal with no risk factors, it's unlikely. So there is that protective factor.
Do you think that given the same risk factors, women present 5 to 10 years later than men with significant coronary artery disease?
I do. I do
And
think they present
so
later.
that still exists.
That still exists. But I still don't think, if they are, even if they're presenting earlier with traditional risk factors, we should
Sure.
take them seriously.
Got it.
We recently published a paper about 6 base differences in prevalence and outcome of common conditions associated with type 2 diabetes, type 2 myocardial infarction, meaning those patients who come to the hospital with AFib RVR or decompensated heart failure or septic shock or pneumonia, and they have a bump in troponin. And I think, Abir, you get a lot of these consults. A lot of general cardiologists also get these consults. You have elevated troponin setting of acute illness. Well, actually, the project was led by Mamas from England. But when we looked into this more carefully with the data, women has worse outcome. And that's a specific situation, cohort of patient, regardless of age. And when we control for all multiple risk factors, diabetes, hypertension, just gender by itself is higher, which is allude to the fact also, that's why in the CHA2DS2-VASc score for AFib, being a woman is already have a point. So I think we already know it's a serious problem for women, but I think in terms of prevention, we didn't jump early on to treat women as aggressive as men who are exposed to heart disease. But your slides illustrated nicely in terms of premenopausal, postmenopausal. But the main thing I should take that I learned from today is I should elaborate, regardless how aged the patient is, I should ask him about preeclampsia and if they developed any gestational hypertension or diabetes.
Just adding to what you said, I mean, I was talking about NSTEMIs and how women tend to have worse outcomes in the hospitals after that. If you go the invasive route with them, they're more likely to bleed. They're more likely to develop CHF, and they're more likely to develop shock, and they're more likely to do worse if they develop shock. So I think that goes hand in hand in general. And they're not 100% sure, but there's more diastology in women, more LVH in women, more hypertension in women. They think that plays a role. So I don't know if that plays a role in the demand ischemia patients as well. But it's something to note.
Absolutely. And you mentioned about the HFpEF and preserved ejection fraction. All of the majority of the patients we see are women with and the number one thing we have to rule out is coronary artery disease as a risk factor. Men mainly are sleep apnea, obesity, and other stuff, but then women is a CAD, especially elderly women coming with atypical symptoms. Underlying coronary disease should be ruled out.
And then back to the CHA2DS2-VASc. So being a female alone is not you can't count it as one. And then some people may argue that maybe you need a CHA2DS2-VASc of 3 to really anticoagulate women because they're getting a point just for being female. So I'm not sure if they're really at risk for thromboembolic events from, AFib compared to men.
So what is your practice usually for AFib?
So, I mean, again, if they're just a CHA2DS2-VASc 1 because they're female, I consider that a CHA2DS2-VASc 0.
Yeah, absolutely. Yeah.
And otherwise, I'll try to push it at 2, but I've had some pushback, so I let them go until they hit 3.
Right. Yeah, because women in hypertension, and you're already done. I mean,
Yeah, that's what I mean. So a lot of them, I have a lot that are women in hypertension and they refuse to. So I'm like, okay, once you develop the age in there, then you're going to get.
yeah, right.
Yeah.
And we see this a lot in post-op, Dr. Zair, and the practice of surgical and SICU and DMC is they empirically start all patients on amiodarone to prevent the burden of AFib. But definitely, if they have no episode, then we stop it before they discharge or a month after.
Well, AFib post-operatively is equal, as far as I know, in men and women, and we don't know all the etiologies. And looking over our past year, obviously we're doing something right, because our post-operative AFib rate is 17%, which is markedly less than the state and the national levels. So I think there's a variety of reasons for that, but I think prophylactic amiodarone has been helpful.
Absolutely, yeah. And again, it goes to our points. If just being a woman give her anticoagulation, that's a big deal. Kind of having a woman on anticoagulation for just being a woman in hypertension. Well, I think we are coming to 3 minutes left. We answer all the questions for the audience. I would like to thank Dr. Berry for your time and for phenomenal presentation about women's heart disease, starting from prevention all the way to management of patients with coronary artery disease. Thank you so much for your time. I'd like to thank Dr. Zair for your time and participation and phenomenal surgical input and moderation of the session. We have more of these sessions coming up. As I said, every last Thursday of the month, we have a series coming up. Soon we'll get an invitation again for our audience and people who signed up. Thank you so much for joining us. We'll cover arrhythmias. We're going to cover congenital heart disease. We're going to cover also valvular heart disease down the line. Dr. Zair, any final comments?
No, I also want to mention and give a shout out to our organizers that we're pretty happy with this series, this symposium that's going on thus far. We look forward to further viewers chiming in and asking more questions. And remember that these sessions are recorded, and so therefore you can go back through and review the data that Dr. Berry presented today, and that can be helpful too.
Absolutely, yeah. These guys all these videos are recorded, and maybe within 2 weeks will be on the YouTube channel for DMC, and definitely we'll share it with our audience and on all different social media platforms. Dr. Berry, thank you so much for your time and for being with us today.
Appreciate it. Thanks.
I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.